Bismillahirrahmanirrahim. In this video, we are going to discuss the diseases of the basement membrane zone, and it especially includes systemic lupus erythematosus. My name is Professor Dr. Naseem Ahmed, and I am working at Tau Medical College, Karachi, as Professor of Pathology. These are the references for this video. There are many diseases that are included in this category of the diseases. These are epidermolysis bullosa, bullous pemphigoid, dermatitis herpetiformis, erythema multiforme, and lichen planus. The epidermolysis bullosa, bullous pemphigoid, and dermatitis herpetiformis are included in inflammatory bowel disorder, while erythema multiforme is studied under the acute inflammatory dermatosis, while lichen planus is considered in chronic inflammatory dermatosis. The other diseases of the basement membrane zone are systemic lupus erythematosus. Systemic lupus erythematosus is characterized by presence of autoantibodies and immune complexes that are deposited in the skin. So in systemic lupus erythematosus, there is epidermal zone, basement membrane zone damage, and this is initiated by exogenous stimulus or ultraviolet light, and it is sustained through cell-mediated immune reaction, and it results in the injury in that area. And there are both the lesional areas and the normal skin both show the deposition of the immune complexes, and the especially the presence of the immune complexes in the normal skin is characteristic for the diagnosis of this systemic lupus erythematosus. This injury morphologically shows vacuolization of basal keratinocytes, hyperkeratinosis, diminished epidermal thickness, release of DNA and other nuclear and cytoplasmic antigens to the circulation, and deposition of DNA and other antigen in the epidermal basement membrane zone. There is an inverse relationship between the prominence of skin lesion and the extent of the systemic damage, and so all these factors, the epidermal injury, the local immune complex formation, deposition of the circulating immune complexes, and lymphocyte cellular injury, they all work together in synergy to cause the disease. This illustration is describing the pathogenesis of this lupus erythematosus. The keratinocytes can be damaged by exogenous or endogenous factor, and this damage result in release of the antigen, various kind of antigen, into the circulation, or some of these antigen may return to this area in the form of antigen antibody complexes. So these antigens may be DNA and other antigens that are secreted from, that are released from these keratinocytes that have got the damage, and these antigen antibody complexes, when formed, they then deposit within the lamina densa and the dermis just beneath this area. The types of the systemic lupus erythematosus that have been described are acute systemic lupus erythematosus, subacute cutaneous lupus erythematosus, and chronic cutaneous, that is also discoid lupus erythematosus. The chronic discoid lupus erythematosus is limited to the skin, and it is localized above the neck or face, especially the malar area of the face, scalp, and ear. Morphologically, the early lesions exhibit slightly elevated violaceous papule with a rough scale of the keratin, while late lesions enlarge and they assume a disc shape with a hyperkeratotic margin and a depigmented center. The scar is present, and in 10% of the patient there is increase circulating anti-nuclear antibody level. This picture is showing the Lupus Erythematosus rash, that is also called a Meller rash. This is reddish in color and it is also termed as butterfly rash because it has got a reddened skin across the cheek, and this suggests Lupus Erythematosus. There are some lesions that are sharply demarcated and discoid in appearance, and they involve mainly the skin, and they do not exhibit other organ lesion, such as occur in systemic lupus erythematosus that damage kidney and other organs also. The morphology of the chronic discoid lupus erythematosus is characterized by presence of nucleated epidermal layers, and there is modestly thickened or somewhat thin layer. There is presence of hyperkeratosis, but parakeratosis is absent, and plugging of hair follicle is present also. The dermal epidermal interface, especially the retipapillae pattern, is partially effaced, and basal keratinocytes are vacuolated with presence of eosinophilic apoptotic bodies. The lamina densa is thickened and reduplicated, and these are composed of multiple layers that extend into the subjacent dermis on PS or periodic acid shifts reagent stain. There is diffuse lymphocytic infiltrate, and it penetrates basal layer focally, and dermis has got dense patches of helper cytotoxic suppressor T lymphocytes, often with plasma cell around the skin appendages. On immunofluorescence, there is presence of immune complexes deep to lamina densa on the lamina densa, and lamina densa and lamina lucida are show that these immune complexes are granular in appearance. This should be differentiated from bullous pemphigoid, in which these immune complexes are linear and are present in lamina lucida. This photomicrograph is showing the changes associated with lupus erythematosus. There is presence of lymphocytic infiltrate in the upper dermis, while the basal layer of the epidermis is vacuolated and showing dissolution. So this photomicrograph, it's a low power view of the skin, and it is showing that there is lymphocytic infiltrate around the vessels and around the skin appendages. Then this histological appearance of the uh, systemic lupus erythematosus of showing the changes in the skin, and there is necrosis of the basal cell, and there is keratinocyte migration, basal keratinocyte migration, and there is synthesis of new basement membrane. The basement membrane is thickened and reduplicated in this systemic lupus erythematosus. There are vacuoles on each side of the basement membrane that are marked by these arrows, and they indicate the cellular injury. This is periodic acid shift reagent stain. This photomicrograph is showing that there is basal vacuolization with keratinocyte necrosis, and these necrosis forming dense apoptotic bodies. These are eosinophilic in nature, also called as fibrillary body or colloid bodies. There is surrounding infiltrate by the lymphocyte. This immunofluorescence stain is showing an active lesion of lupus erythematosus. There is bright green band of the fluorescence that is stained by antibody to immunoglobulin G. These immunoglobulins are localized at the dermal epidermal junction, and this is typical of immune deposition disease. These complexes are formed from antigen antibody or type 3 hypersensitivity reaction, and they are trapped near above the lamina densa, and area adjacent to it. The subacute variety of cutaneous lupus erythematosus affects young and middle-aged white women most, and it is associated with the musculoskeletal system and kidney involvement. Morphologically, this is a scaly lesion that is erythematous, and development of papule is also there, and these enlarge into psoriasiform or annular lesion and then fuse. The site of these lesions is upper chest, upper back and extensor surfaces of the arm, the area that is exposed to the light. It is not associated with the scar formation, and on serology, anti-Rho antibodies and ANA antibodies are present in 70% of the cases, and microscopy is characterized by edema of the papillodermis, thickening of the lamina densa, the vacuolar degeneration of basal keratinocyte, and there is mild lymphocytic infiltrate in the basement membrane zone. The acute variety of lupus erythematosus is associated with kidney and joint manifestation in 80% of the cases, and it usually presents with the malar rash, the butterfly rash that we have seen earlier. This butterfly rash may precede the onset of the systemic symptom few days to few months earlier, and this disappears. This malar rash may disappear within few hours to few days. Then this site is the sun exposed site such as chest and extremities. On morphology, there is a maculopapular rash or eruption, and this is indistinguishable from the discoid lupus. So they are not associated with the scar formation, and on serology, 90% of the cases are associated with increased anti-nuclear antibodies level. Thank you very much for your attention. If you have any query, you can email me on the email address that is given in the start of this video.